Diabetic polyneuropathy is a serious diabetes complication seen in approximately 50% of individuals with long-standing diabetes. It is a major cause of peripheral nerve injury due to long-term hyperglycemia and glucose intolerance. Nerve impairment is followed by microvascular dysfunction that affects the nerve vascular network. And this is due to oxidation, which is caused by hyperglycemia and other disorders of homeostasis and metabolism. Okay, looking at the pathophysiology of diabetic polyneuropathy, we know that it involves many nerves. It is the most common type of distal symmetric sensorimotor polyneuropathy and a frequent complication of both type 1 and type 2 diabetes. We know that it involves injury to somatic sensory, motor nerves, and automatic nerves, where all sizes of sensory axons and myelin are damaged. And this causes dysfunction, which results in symptoms such as pain, paresthesias, dysthesias, and affects sensation severely, often in a stocking glove distribution. We know that dysfunction is caused by damage to axons and myelin sheaths, and sometimes even to both. Okay, looking at the signs and symptoms of diabetic polyneuropathy, we know that symptoms are minor at first, and many mild cases may go unnoticed for a long time since most nerve damage occurs over several years. We know that symptoms include decreased sensation with pain, paresthesias and dysthesias, defective thermal sensation, impaired vibration sense, decreased ankle reflexes, joint stress, and damaged joints. We know that as the condition progresses, more nerve fibers are affected. Symptoms include muscle weakness and atrophy, sensory loss, numbness, paralysis, loss of reflexes, changes in gait, ataxia, which is impaired coordination, motor movement problems, paresis, decreased sweating, foot deformities, severe ulcers, and amputations. Symptoms usually start in the peripheries and gradually progress more centrally, and the autonomic nervous system may also be affected. Okay, we know that some patients may also experience increased hyperalgesia, pain from painful stimuli. Other patients experience increased sensitivity to touch, a poor altered sensation in the extremities that slowly progresses to more proximal areas. Some patients may experience impaired perception of pain, defective thermal sensation, numbness, abnormal joint stress, damaged joints, muscle weakness, atrophy, and a loss of reflexes. Severe ulcers, changes in gait, difficulty walking on heels, decreased sweating, foot deformities, collapse of the midfoot, blisters and sores on numb areas of the foot, amputation, and diminished vibratory perception. More symptoms include decreased knee and ankle reflexes, a diminished ability to sense position of toes and feet, gastrointestinal digestive problems, persistent nausea and vomiting, sweating abnormalities, sexual dysfunction, and low blood pressure. Okay, looking at the effects on movement control, we know that as diabetic polyneuropathy progresses, symptoms of distal sensory loss, absent tendon reflexes, muscle weakness, and muscular atrophy all have an adverse effect on movement control. Muscle weakness is a sign of peripheral motor nerve damage, and it is closely related to the severity of the polyneuropathy. Muscle weakness is found to be paralleled by muscular atrophy, which is observed in the feet and the legs of patients. Muscle weakness is also related to the slowing of movements, unstable gait, and more frequent falls. Okay, treatment of diabetic polyneuropathy involves lifestyle changes and medications to control the diabetes, pain, and other complications. Controlling blood glucose levels is the basis of treatment because excess of glucose is responsible for nerve damage and lack of regeneration. Nerve dysfunction can be stopped and nerve fibers can improve once glucose levels reach a normal level. Early diagnosis can stop the progression of diabetic neuropathy, but usually medications are needed to help patients deal with the neuropathic pain. Antidepressants, anti-epileptic drugs, opioids, and anticonvulsants are preferable options due to their efficacy. Also, diabetic foot screening is recommended and regular foot examinations should be performed to determine a patient's risk for developing diabetic foot ulceration. In addition, exercise prescription and balance training may improve strength, postural stability, and walking performance. Studies show that patients respond to resistance training and aerobic training with improvements in glycemic control and with lowering of blood lipids and blood pressure. Regular strengthening exercise also improves muscle strength and reduces neuropathic pain. To conclude, the number of people with diabetes is rising, and diabetic polyneuropathy imposes a substantial health and economic burden. There is a need for new therapeutic options to improve the standard of care. Thank you, and have a nice day.